Our speakers today are Rich Murphy and Clark Averill. Rich is Vice President of Interface Software at Iatrix Systems. Rich has a Bachelor of Science degree in Engineering, a Master of Science degree in Computer Science, and more than 15 years as a healthcare IT professional and integration strategy expert, in addition to being an experienced programmer. He joined Iatrix Systems in 2003 to oversee interface development, implementation, support, and day-to-day operations. Clark is the Director of Information Technology at St. Luke's Hospital in Duluth, Minnesota. Clark was appointed Director in 2000 after serving in IT management and leadership roles at St. Luke's beginning in 1994. Clark is active in HIT through Minnesota and currently serves as the Board Chair of the Community Health Information Collaborative, the only state-certified HIO in Minnesota. Clark received his Bachelor of Science degree in Electronics Engineering Technology from Missouri Institute of Technology. Now I will turn it over to Rich.
Thank you, Amanda. Wanted to welcome everyone to our call today. Also wanted to thank Clark for taking a few moments today to discuss how his team and Iatrix work together to create real-time bidirectional integration between his physician practices and the hospital HIS system, automatically place physician orders on a work list to be reviewed and placed when the patient presents at the hospital, and eliminate the need for users to re-enter patient data when a patient transitions from one facility to another. At this time, I'd like to turn it over to Clark to give us a little bit of background information about his organization.
Thank you, Rich. Like Rich said, my name is Clark Averill. I've been the Director of IT here at St. Luke's for, going on 14 years, been at St. Luke's for almost 20. St. Luke's is basically, I'd call us a mid-size IDN in northern Minnesota. We have two hospitals, a 267-bed tertiary hospital and a critical access hospital. We also have 38 physician practices with 215 employed physicians. Our technical environment is, for the hospital, we're a Meditech client-server 566 shop, and we have eClinicalWorks as our ambulatory system. And eClinicalWorks, actually, we have 4 separate EMRs in our clinical system in our ambulatory setting. So that's a little bit about St. Luke's.
All right, thank you, Clark. Appreciate that background information. Talk to us a little bit here, Clark, about, before the Iatrix physician office integration solution was put in place, what were some of the key challenges that you and your organization, the providers, patients, et cetera, were running into? What kind of challenges were you guys seeing?
Sure. Well, I think we need to take just a step back and talk a little bit about our older environment. When we selected Meditech in 2002, we also selected LSS as our ambulatory system. In 2008, we came to the realization that LSS wasn't scaling to our ambulatory care setting. So in 2010, we started searching for a new ambulatory care product. We selected eClinicalWorks. Because we were leaving that integrated environment where we had a shared med list, shared allergy list, common master patient index actually, that changed our world quite dramatically from an information technology standpoint. So what we really needed to address was this 2 EHR system, one in the ambulatory care setting, one in the acute care setting, and we wanted to make sure that we didn't lose any of those efficiencies that we had from that single integrated system. And so our concern was, how are we going to get clinical orders and results back to the clinicians very quickly? How can we get rid of the faxing of orders from some of our, even on our on-campus clinics, we'd fax orders to radiology, for example. And we wanted to provide our patients the ability to go to any location in our health system to get their tests done, whether they be lab tests or radiology. St. Luke's covers an area of about 17 counties in northern Minnesota, and we have practices within around 70 miles away from us in virtually every direction. And if we have a patient come get an order while they're at a specialist, we want them to be able to get those follow-up labs and radiologies done closer to their home so they don't have to come all the way to Duluth. And we needed a product that would really enhance that workflow as we let the patient be there. And then iAtrix was a critical component in being able to provide that work list. The other issue that we wanted to address with our older system, when a lab order was entered in to the ambulatory product, it would be transferred to the Meditech lab module. And our Meditech lab module is our reference lab system and our lab system for all our clinics. If it had a future date on it, we'd have to put in an estimated future date of when we wanted that lab collected. And if the patient didn't present within 7 days of that future order, that order basically would drop off Meditech. It would be purged. And that created a lot of workflow issues if patients were late in coming for their lab test. So if their lab test was ordered on the 1st and they didn't show up till the 8th, the order was gone out of Meditech, which caused a lot of rework. As you know, you had to call the physician office, see if that order, see if they could retransmit that order or rekey it into Meditech directly. So that was something that we wanted to address, and we were able to address that issue with the iAtrix work list as we looked at the physician office integration suite.
Great, thanks, Clark. Appreciate that detail there. I'm sure that many of our attendees here today are probably facing similar challenges to what you described there and what you guys were seeing. Talk to me a little bit. What were some of the reasons that you went with iAtrix? Pretty significant problem there that you were trying to resolve. What were some of the reasons you went with iAtrix to put a solution in place there for you?
Well, one of the reasons is we had an existing relationship with iAtrix, so we knew the scope of work that they had done for us in the past. iAtrix has always been viewed, in my estimation, from a Meditech perspective as kind of one of those key integrators that does a great job of integrating Meditech into other environments. In fact, because Meditech in the past historically has been very unwilling to do that integration internally, that most people went to iAtrix or had to find another vendor to do that, and we had chosen iAtrix. We had used iAtrix for some custom programming. We had been searching for an interface engine, and because of our tight relationship with Meditech, we actually selected the iAtrix Jaguar EasyConnect. It was EasyConnect at the time. It's now called Jaguar, to be our interface engine. And so as we were looking to do this major conversion from LSS to ECW, we really pointed towards iAtrix almost right away, and we actually engaged iAtrix in several phases of that project, both the data migration phase and the interfacing of the physician office integration suite. So we had a real comfort factor with iAtrix and the scope of work that they did, the quality of work they did, and just a really nice working relationship.
Thanks, Clark. Talk to us a little bit then about, once the iAtrix physician office integration solution, which, we worked closely with your team to scope out and put in place to meet your specific needs. Talk to us a little bit about, once that was in place, how did that solution solve these specific problems that you were trying to get resolved?
Well, one of the big things that you struggle with from a two HIT system perspective is how do you identify the patients? How do you move results, move orders between systems? And so we really needed to be able to create many bidirectional interfaces. And bidirectional can mean different things depending on the interface. But the first key one is a bidirectional ADT interface, where if a patient presents at the hospital and you've never seen them before in your system, how do you ensure that that patient record is also created in your ambulatory system? If the patient presents in the ambulatory clinic, how do you make sure that they're also in your hospital system? And that's very critical, because we rely on so many of our hospital systems to be those departmental solutions, especially in our lab and radiology. Those are viewed as those modules where that work gets done and then gets back to the ambulatory product. So having a bidirectional ADT was critical, and that was one of the key components when we selected IATRIC, that they could do that. We also wanted to make sure that we didn't lose that ability for the ambulatory doctor to order the test, have it be transmitted real time, be available in that module, and then when that lab or x-ray or other type of diagnostic test was done, to make sure that result came back into ECW and was available for the physician to review. And so we needed to make sure that that was real time and that we didn't have a lot of errors. I mean, we just don't have time to babysit. Just to kind of give everybody a scope of work, we see about 500,000 patient visits per year in our ambulatory clinics. So almost, you know, a large portion of those patients end up with lab tests, some type of diagnostic tests. So we have a lot of orders flowing, you know, real time through the system. And we result approximately 6,000 lab tests a day, which flow back to ECW. And so, you know, you need to make sure that you have that workflow, and we needed to address some of those concerns, like I mentioned earlier, with the orders just dropping out of the Meditech system because they've reached a date of maturity. And one of the ways that we did that was with the IATRIC work list. We also wanted to retire some other third-party integration suites that we had purchased. We had gone down the road with another vendor for some integration into a different ambulatory system that wasn't our ambulatory system, was actually an independent physician. So we wanted to be able to retire that and do that work all in one interface suite, and we were able to accomplish that goal.
Thanks, Clark. What kind of things are you hearing from your staff, you know, now that we have the solution in place? We worked together to put both sort of, you know, standard functionality that we had in place off the shelf, if you will, and we did, of course, put some customization in there for your specific workflow and needs. What kind of things are you hearing from your team and your staff since we put this in place and took this up?
You know, I think the best thing that I hear from staff is I don't hear from staff.
Right.
Our physicians just expect things to work 100% of the time, and the interfaces that we've developed have been extremely stable, and thus we have very, very, very few issues. When we do have an issue, and we do have an occasional hiccup, and it tends actually to be more on the vendors, not the IATRIC side, but on the ECW side. They've got a couple of worker jobs that can have problems. We hear about it very quickly. Our workflow in our clinics is that oftentimes the physician will come in, see a patient, order some labs. Those labs get drawn in the clinic, get resulted in the clinic, and then the physician comes in and reviews those results with the patient while they're still here during that one visit. And so that time frame is extremely critical, that lab result get back very, very quickly as soon as it's resulted. And we see that in action on a daily basis. We get the lab result back from Meditech and into the ECW EMR within a minute of it being resulted in Meditech. And that is an extremely important factor for our physicians because of their workflow. I think the big improvement that we really saw that the registration staff love is in the lab and in the radiology area. The IATRIC work list works much better than the process we had in place when we had LSF and Meditech. All of the orders for lab, if they're a same-day order, they automatically go to Meditech. Nobody has to do a registration. They're just automatically there. If it's a future order or if it's a radiology order, those orders all go to a work list. And so when the patient presents, the registration staff pull up the work list, they're able to select the patient. Once they select the patient, they also see what other orders are on that patient, and so we can bundle some of those tests, especially because we have multiple specialties. A patient may be ordered by an orthopedics doc and potentially even a family doc to get 2 different types of tests depending on their care, and we can bundle those so we don't have to stick the patient twice, and that really only happens because we have the IATRIC work list. So it's really critical that we have that. And the other part that we hear a lot of is the coordination between the ADT systems and having that one master patient index. We're able to keep our patient list in sync, so to speak. With 2 EHRs, you basically have 2 master patient indexes, and we're able to keep them in sync via the bidirectional ADT interface that IATRIC was able to develop. And that's kind of unique, and all the other customers that I've talked to, we're one of the few sites that I've found that had that bidirectional flow working well.
Great. Well, thank you, Clark. You know, working together with your team, our team is definitely very, very pleased on our side with the final outcome as well, and we're satisfied and proud of the fact that we were able to work with you and your team to make sure that we addressed all the challenges you were seeing. You definitely have, with that many practices and that many physicians, you definitely have a lot going on, so we were happy that we could come in there and help out. At this point, I did want to open the line for any questions that any of the attendees may have for Clark or myself here today.
Okay, I have unmuted the line, so if you have a question, please feel free to speak up, or you can send it through chat, and I'll be glad to ask for you. It looks like we do have one here in chat. What do you use to match patients between Meditech and ECW?
Yeah, that was actually a very critical component of developing the integration suite. Because we have 2 hospitals in our Meditech EMR, we basically had 2 medical record numbers. We have a medical record number for St. Luke's and a medical record number for our Lakeview Hospital, which is our critical access hospital. And that presents a problem because most of the time you're going to try to match on medical record number, and of course ECW has you know, their account number, and they don't really have a medical record number, and so we couldn't really use a medical record number as a match. And so in Meditech, Meditech has a number that's called a URN, a unit record number, which is actually the upper level number that ties multiple medical record numbers together in your EMR. And so we were able to, with IATRIC, to access that field, to put it in the HL7 message, and send that off to ECW, and then ECW was able to store that in their system, and that really provides the matching. And so what happens is if a patient presents in ECW and we don't have a record of them, we create a new record. We send an ADT message to Meditech. IATRIC takes that, searches for the patient, finds out if the patient's there. If the patient isn't there, it creates the new patient in Meditech and then returns that URN number to ECW. If the patient is in Meditech, it returns that URN also. And so ECW is storing the URN, and that is our match between the Meditech system and the ECW system. But it's kind of unique, and some of it is because of our configuration of both Meditech and ECW. But you know, we were able to accomplish that, and IATRIC was able to program around that, which was really critical to our success.
Yeah, and just to add to that, Clark, like you said, so you know, that kind of a unique problem, but you know, we also do see it out there with other EMR systems, and that matching up their identifiers with the Meditech visit number and identifier, and just some data points that we would typically use there with the ADT message that you mentioned. We can check the hospital system, first name, patient's first name, last name, middle initial, date of birth, next to kin, things like that, to line up the the correct patient and return that back. Or like you said, if we don't have a match, we can put that on the work list for a human user to manually make that decision, or we can go ahead and place a new visit right then and there. So we have some options there and some flexibility depending on what the hospital wants to do.
Okay, thank you both. Just a reminder, the lines are still open, so please feel free to speak up if you have a question. Okay, we have another one that has come through chat. Our physicians are concerned about having to live in 2 EHRs. What did you do to address that issue?
Yeah, that's a great question, and one I actually get a lot. One of the problems that you have when you have 2 systems is the physician, when they're in the ambulatory world, especially if they're an on-campus specialty physician because they're seeing patients in the hospital, they end up having almost to jump through 2 electronic health records to find that information. And so we really strive to not have that happen. What we did and what Iatrix enabled for us was to take all of the information that is coming out of Meditech via ITS or the lab module and send that data to ECW. So not only do we send orders to Meditech and get those results that would be resulted against that order, we also send all lab results, whether they be especially if they're done in the acute care setting, we send all those lab results unsolicited over to ECW. Also, any hospital documentation like a progress, a discharge summary, an operative report, a diagnostic report, an echo report, all of those different types of reports come out of ITS, and we send all those to ECW also, so that those are available in the ECW EMR. From a hospital perspective, when a person is caring for the patient in the acute care setting, they really do need to see some of the ambulatory information, and that really hits you in urgent care and the emergency department, because the emergency department wants to see what happened last. And those emergency doctors don't really want to leave Meditech and leave their ED module and jump over to eClinicalWorks, especially if they don't know if there's something to see there. So when a physician in eClinicalWorks locks their progress note, which is equivalent to signing the note in ECW, that note gets sent from ECW to Meditech via the Iatrix interface. But Iatrix needed to do a kind of a special routine for us in that case, and what they needed to do is we didn't have a place in Meditech to really put that note. There was no, you don't want to put it on that same acute care visit. That doesn't make sense clinically, and everything in Meditech is visit-based. And so what Iatrix was able to do is they see that progress note coming from eClinicalWorks. They basically do a short registration of a clinical visit, a clinic visit is what we call it, or a documentation visit, and then they put that progress note on that documentation visit. So it's available in our Meditech EMR under the other reports panel, and our ED physicians find that invaluable because that progress note will have the last med list, it has the allergies, it has the notes of the last visit. And so as you're caring for a patient, especially in the emergency care setting, you need that information. And so the physicians don't need to jump out of any system. They already have all of the information. And it really keeps those 2 EHRs kind of in sync from an EMR perspective. If a result is in one, it's in the other in almost all cases. And that was a critical component to physician satisfaction. Rich, I don't know if you have any other comments about that, but I think that functionality of getting that progress note back into Meditech was critical.
Right, that was definitely something that, we sat down with your team and defined how you guys needed that to work, and we came up with that solution to put that back into the ITS application in that case as a textual, type of note, and then, like you said, then it's available in the EMR. And just to also add that the bidirectional integration here, as you mentioned, Clark, is real time. So in your workflow example, as those results are happening in Meditech, or really any of the HIS systems, the lab results, radiology results, as new results are placed and existing results are manipulated, those are sent back out to the practices real time. So there's no real delay there. Just like you said, the practices should have a real-time snapshot of what's happening in Meditech. And then same with that progress note. As soon as we receive that, we put that back in so that there's that real-time snapshot on the hospital side, of what's happening out there in the practices.
Yeah, and I can just add to that how critical it was when we first implemented eClinicalWorks. Iatrix was able to send the results real time, and so we were getting them to eClinicalWorks literally within seconds of them being resulted in Meditech. It is that real time. But we found an issue with ECW when we went live, that they process the results sequentially, and the way that their interface worker jobs work is they would only take so many so fast, and we found that we were overwhelming that sequence of how fast they could process those results, and you can't believe how many physicians were calling and complaining about that 5-minute, 6-minute delay of those results getting back, primarily because it affected their workflow in caring for the patient in the ambulatory world. And so you don't really think about how critical it is to have a very, almost real-time system, but it's critical. I mean, there are some results that don't need to be as real-time. An X-ray report usually isn't quite as critical, but those labs were extremely important. We were able to work with ECW to address that problem in their system, but it was not an Iatrix issue. Iatrix was getting the information to ECW in plenty of time. It's just that ECW just couldn't process it. But we've addressed that problem and have it fixed now.
Hey, a 5-minute delay might not sound like much, but right, it is.
It is, especially when you got a patient waiting around. It's a big problem.
Now more than ever, right?
Okay, thank you both. The next question in chat is, please describe how ambulatory documentation is available in Meditech.
Yeah, I already kind of touched on that, but I'll just kind of recap that. Basically, when a progress note is signed or a visit is signed in ECW, we get an outbound HL7 message. That HL7 message flows through our interface engine into the Iatrix Interface Manager, which is the Meditech side of the Iatrix system. The Iatrix system then looks at that, sees that that's a progress note, identifies the patient, creates what we call a document visit. It's a visit that just is for documentation. Creates that visit in Meditech, then gets that visit number basically, attaches it to that progress note, and then sends it through the ITS interface with that visit number, so it attaches directly to that visit. So it comes in like it was a transcribed report. It obviously is not a transcribed report. It's coming from ECW, but it flows just like that. And we're able to, because we're able to identify the document type and the document name, we're able to use all the ITS tools to put it in the other reports section or panel of the Meditech EMR in the appropriate place. And we actually label those progress notes by specialty. So in Meditech, if a physician's going out and they want to see what the cardiology progress note looked like, or it was an orthopedics progress note or a family practice progress note, the physicians can easily find those types of notes in Meditech. And again, it keeps the physicians from having to go to ECW to look for notes and not knowing if there was even a visit. And so they can see that all on the Meditech side of the EMR, and that is a real, I'm not going to say it's a satisfier for physicians. I think it just kept up the same workflow they already had, but I will tell you it would have been a dissatisfier if we wouldn't have had that ability to do that as we implemented ECW.
Yeah, and like you said, Clark, so workflow-wise, they're in Meditech. They don't have to leave Meditech. They go into the EMR, and under the reports panel, which is just part of the EMR, those are all right there.
Yep, that's correct.
Okay, thank you. We have another question here. What was your biggest challenge in getting the interfaces operational?
You know, I think our biggest challenge was truly and honestly, I think we spent the most time testing the bi-directional ADT interface. The idea, all the different scenarios of a patient already exists in Meditech, and they're coming into the clinic. How do you match that? How do you match if you get a new patient at the hospital, making sure that they're going to be available in the clinic? And the reason that's important is because when they're in the hospital, we're sending all of their information to ECW. So we need to make sure that that patient exists in the ambulatory product so that we have a place to have those lab results and x-ray reports and discharge summaries, and all of that needs a place to land. And so if the patient's not in the EMR, in ECW, you know, those documents actually air out. And so we actually have staff that just make sure that all those patients are in the same place. And so we were testing all those scenarios, and I think that took us the most time. And I think, you know, we were kind of a challenge for ECW and IATRIC and Meditech because we have a pretty complicated environment. We have 2 hospitals on the Meditech side. We have 4 ECW EMRs, 1 big ECW EMR for our main physician group, but we also have the critical access hospital owns their own clinic, so they had to be separate in ECW because of the tax ID and billing. We also host an independent physician's EMR as a hosted service, and so we have 3 EMRs, and so we're trying to make sure that all the lab results and all the x-ray reports all flow appropriately to all those different EMRs. Just really a lot of testing, but you know, the great thing was it was such a good experience working with IATRICS. We just sat down, we talked about what the goals, we did a really good scope document, we basically sat down, got it all worked out really on paper, and then we implemented it, and IATRIC was able to really do some really cool stuff for us with the IIM, both to get the progress notes and do the patient matching for the ADT interface.
Yeah, just like you mentioned, Clark, that I think that progress note, it wasn't something that we originally had in mind right on day one, but it just sort of evolved, and the docs had a question, and we figured it out and put that in place.
That's totally true. We had not identified that as something that we really needed to do. It was almost, I wouldn't say an afterthought. It just really became obvious of how we going to get that information back into Meditech, and we hadn't thought about it. And of course, you know, that some of those interfaces, I think, over the course of time, may be replaced by the transition of care documents to CCDA type of format flowing between systems. And we're actually going to be using IATRIC for that. We have that software from IATRIC. And so as we move some of those interfaces maybe away from HL7 to some of the more standardized, you know, new standards to meet the meaningful use things, especially from a patient portal perspective, we know IATRIC is going to be there in our corner to help us with that transition.